begin to inflate. Look how the color changes from that red nastiness of liver to a nice inflated lung. Look how the tidal volume needed to ventilate that lung decreases. And then, in a few seconds, the investigator is going to start taking the beat off again. And look what happens. How the lungs collapse down to looking like liver. Think of the shear force that needs to be given in order to try and open that lung, and the high tidal volume that needs to be given. This is why we said last time that even if you're trying to give a normal tidal volume, if your lungs are not at optimal mean airway pressure, you will still damage the lung. You will still damage the lung if you're not using optimal mean airway pressure. And I think a picture is worth 1,000 words there. Okay, so now we're going to start talking about oscillation. And then next time we're going to talk about jet ventilation. I forgot last time to put in my disclosure, so I have nothing to disclose, even though I've done many talks for both Vanel and Care Fusion. They're always sponsored by universities and not for them directly, at least not in the last couple of years. Okay. Always learn from the mistakes of others. You don't have enough time to make all of them yourself. So it's one of the reasons that we have to read the literature, and we have to try and make the best that we can of the literature. I'm trying to provide you with each of these talks with some references that I think are very useful. These references I've picked for several reasons. The first one by Philip Cools, and all really involves all of the people in the world that have been studying high-frequency ventilation in the last 30 years. And this was an individual patient meta-analysis. And we'll spend a little bit of time talking about what that showed and what some of the pitfalls are. Our group, the neonatal ventilation study group, published a large trial several years back on high-frequency versus conventional ventilation. And there are some reasons that I picked that one, because the way we did the study is quite different from how everybody else has done their studies. So I think there are some questions that need to be asked in reference to those differences and what they may mean. Jane Pillow is one of the world's most predominant pulmonary physiologists, studying not only high-frequency oscillation but high-frequency jet ventilation. And she's published many, many, many articles on high-frequency oscillation. This one I find particularly useful, high-frequency mechanics of gas exchange and lung mechanics in critical care medicine a few years ago. If you want more information on the things that I present today, there's certainly a lot of other articles out there, but these are three that you might want to review. All right, so I'm going to have a couple of things comparing and contrasting the jet and the oscillator, but mostly I'm going to spend today talking about the oscillator. I just want you to keep in mind some of the things about the jet, because it's a little bit different, and we'll talk about the jet next week. You have to keep in your mind some of these differences. Oscillatory ventilation is, a true oscillator is active exhalation. There's some sort of a piston, some sort of a drum inside that not only pushes air forward but pulls air back. There are a variety of ways that it can be done, but it is in fact active exhalation. No conventional ventilator is used with the oscillator that we have today. Now, this is going to change. The patent on the Sensormedics is about to expire, and there is another ventilator, the Draeger, that is putting forth an oscillator, and Marty Kessler and me and some others may be looking at this ventilator in the near future to see if it's at least as good as the Sensormedics. It does not, however, use the conventional ventilator as part of the oscillator. It's a ventilator that can do both. All right? And so stay tuned for that. We'll see what the future may bring. But at the present time in this country, and this is not true in Europe, where there are other kinds of combination ventilators.
So that has a volume guarantee or just pressure?
It has a volume guarantee for the conventional mode. It also has a volume monitoring for the high frequency mode, which I'm not sure how useful that is, but you can actually monitor your tidal volume during the high frequency mode. So it may be useful. We're just going to have to see. Not yet approved by FDA, still under very initial investigations. So stay tuned. We're hoping Stony Brook can be part of that trial, which would be exciting. No conventional breaths are used with the current oscillator. And something that's always a confusion, and I think we need to really understand, is that the oscillator works with an IE ratio. You don't set an inspiratory time. You set a percent of inspiration, right? A percent of inspiration. You set 33%, okay? What does that mean? That means that no matter what hertz you're using, the inspiratory time of the cycle, and remember, this is where we start using the things we learned about conventional ventilation. Remember, we have an I time, we have an E time, it all goes into the mean airway pressure. So when you're setting that 33% inspiratory time, it means the 33% of the cycle, the push in and the pull out, is inspiration, and the 32% of the time is expiration. That will then vary in terms of the actual time depending on the rate that you set. The only time on the oscillator as currently configured that you can hit an inspiratory time of 0.02 seconds is at 15 hertz. And why do I say 0.02 seconds? Because that is the inspiratory time that is usually set on the jet and not changed. All right, so this is a big difference, and it's something that you really need to understand if you're going to use these machines correctly. And it may play into some of the positives and negatives of these two kinds of machines. So with the oscillator, you set an IE ratio. It's always 1 to 2. It's always 33% at the duty cycle. And on the jet, you set an inspiratory time. The oscillator that we currently use is able to go from 3 to 15 hertz. All right, a hertz, as you know, is 1 cycle per second. We use hertz instead of breaths because it sounds really stupid to say 600 breaths a minute or 900 breaths a minute. So we talk in terms of hertz, which is cycles per second. An oscillator gives us a relatively constant mean airway pressure. It's something that we set. It's not a result of that formula that we talked about last time. Remember that on conventional ventilation, your mean airway pressure is a combination of many things. It's a combination of your peak, which as we know is the most important thing of all, but it also adds in the peak inspiratory pressure, the inspiratory time, the expiratory time, and the rate of the ventilator. On an oscillator, we set a mean airway pressure. We also use the standard endotracheal tube. Just to talk briefly about the jet is passive exhalation. All right, the chest moves inward during exhalation. It is a passive exhalation. A conventional ventilator is needed. It is absolutely needed. There is no way the jet can give peak. It's not in the machine anywhere. If you don't have a conventional ventilator, you have no peak. So that is why we use a conventional ventilator. We do not use a conventional ventilator for breaths. In fact, the current thinking about jet ventilation is to avoid conventional breaths if at all possible. We'll talk more about that next time, but the whole purpose of high-frequency ventilation is to try and move away from tidal ventilation. We talked about the dangers of volume trauma, of shear injury, of stretch injury, of overdistension, of atelectasis. And the whole purpose is to try and ventilate and oxygenate without tidal ventilation. So when you give conventional breaths on the jet, the very first question you should ask is, do I really need this? Or can I manage this baby without conventional breaths, which can be dangerous to this child? The jet functions at 4 to 11 hertz. The IE ratio, as we said, is altered by changing the inspiratory time. At the current time, there is not a recommendation for changing the inspiratory time. There's some work going on, predominantly in Jay Pillow's lab, looking at whether or not under some circumstances having a longer inspiratory time with the jet might be useful. But at the current time, without good data, I would highly recommend that we leave the inspiratory time where the manufacturer recommends it, and that is the 0.02 seconds. Remembering that, as you change the rate on the jet, your IE ratio is going to change. So that's a critical part of the difference that I want everybody to understand. Are there any questions about that point? Okay. Again, with the jet, your mean airway pressure is not set because you are changing your PIP and your peak. Your mean airway pressure will be read by the jet, but you will change it depending upon the PIP that you use and the peak that you use. And again, the most important thing about the mean airway pressure is holding the lung open, therefore the peak. We do need a special endotracheal tube adapter on the jet. It used to be, back in the old days, many of us may remember, we actually had to re-intubate the child, which was, I think, probably one of the main reasons the jet never caught on, because nobody wanted to do that. But then Bunnell came up with an adapter that all you have to do is change the hub of the endotracheal tube. You don't have to re-intubate the baby. That made it a lot easier to use. Okay, during tidal ventilation, the alveoli are going to, at exhalation, be small, and on inhalation be larger as we move that tidal breath in and out of the lung. The purpose, as we talked about last time, was to do that without damaging the lung, doing that by maintaining optimal mean airway pressure, and doing that by using correct tidal volume. During high-frequency ventilation, we're vibrating the lung. We're going to hold that lung at, again, the optimal mean airway pressure, but then we're just going to vibrate the lung. We're not going to have that opening and closing and opening and closing of the alveoli nearly to the extent that we do during conventional ventilation. So, oxygenation, how does it work? Maintain optimal mean airway pressure. Is that any way different from what we said during conventional ventilation? Not at all. These major precepts still apply. For oxygenation, we must maintain an optimal mean airway pressure, no matter what kind of ventilation we're using. For ventilation, there are some differences. Ventilation is due to vibration with excellent gas mixing due to the mechanics of gas flow at very high rates. The mechanics of flow change when you're using extremely high rates. You don't get just the bulk movement of gas in and out and the diffusion of gas at the alveolar capillary membrane the way we talked about with conventional ventilation. Other stuff is happening. This is a very, very simplified way of looking at oscillation. The mean airway pressure, the straight line going across, all right, is set. I want a mean airway pressure of 10. I want a mean airway pressure of 12. It's a pressure that is set by the operator. And of course, it needs to be whatever is needed to keep the lung optimally open. Open lung volume strategy. Somebody had a question about that at the end of the talk last time. It's the same thing. Open lung strategy, optimal lung volume strategy, means you're keeping the lung open, it is not atelectatic, and it is not collapsed, and it is not overdistended. Then what you do is you vibrate, you push gas in, you pull gas out around the mean airway pressure. So you're vibrating, and we call that the delta P. Delta, you remember from your math, means change. P, pressure, change in pressure. The change in pressure from the low point to the high point, all right? Now, as you remember from mathematics, because it's above and below the mean, it cancels out, and the mean airway pressure is the same. However, you have to remember that if you're using very high tidal volumes, you are going to hit higher peaks. So one of the major points of proper use of oscillation is to minimize your tidal volume, because the whole point is to try to keep your tidal volume as low as you can and still get adequate ventilation. So we need to remember that. We need to remember that if we use very high tidal volumes, and it can be done, you're closer and closer to tidal ventilation and what you're trying to avoid for this particular baby. So the primary determinant of oxygenation during mechanical ventilation is mean airway pressure. This is exactly the same as during conventional, and mean airway pressure during HFOV is set directly. When I ask you on rounds, what is the primary determinant of oxygenation on this baby on an oscillator? Your answer should always be mean airway pressure. What is the primary determinant of proper oxygenation on conventional ventilation? Your answer should always be mean airway pressure. Proper mean airway pressure. Now, how do you do that? And that's where the difficulty begins. But there are some things we can do as clinicians to assure that we're doing the best that we can. Optimal mean airway pressure is attained when the FiO2 is at a minimum and when you are on the descending limb of the pressure volume curve. And we're going to spend a little bit of time talking about that. Let me say it again. Your optimal mean airway pressure is attained when your FiO2 is at a minimum. And remember when we said last time, if you've got a high FiO2 on this baby, the first question you should ask yourself is, am I at my optimal mean airway pressure? That's why we say, okay, this baby's ready for weaning. His FiO2 is 35%. Okay, let's wean him. Well, I come back half an hour later, his FiO2 is 30%. Okay, let's wean him again. You wean, you wean, you wean, you wean. As long as your FiO2 is going down or staying the same, you know that you are at your optimal mean airway pressure. The trickier part is, where are you on the pressure volume curve? Now, you've seen this before, you'll see it again. It's my St. Louis Arch slide, and the more boring way of showing it is that you need to be here at the top of the St. Louis Arch. You need to find where you're not collapsed and where you're not over-distended. If you look at the pressure volume curve, this is what happens. Here's pressure along the x-axis, and here's volume along the y-axis. And we all know how important this is. We all know that the slope of this curve is what? Anybody? Slope of this curve is? Sarabi? The slope of the pressure volume curve is change in pressure over change in volume. Okay, this is a problem. Shuttle, you're on for West in December, right?
Mm-hmm.
This is basic 101 medical student physiology. The slope of the pressure volume curve is compliance. All right, you know that in a baby that has RDS, if your pressure has to change a lot for little change in volume, your compliance is very low. All right, this is the kind of situation you'll get.
It's a board question, guys. You gotta know if you have to pass your neonatal boards.
You have to know. You have to know this to even practice in the unit. You have to know this
Thank
to
you.
do anything. This is basic stuff. All right. As you go up with more pressure, and the lung is opening, like the balloon that you're blowing on, and it starts to expand, then you get a nice compliance. All right, well, look, this looks the same. Gee, why is that? Well, because as you go up the pressure volume curve and you start getting a little bit over-distended, what happens? Your compliance goes back down again. That's because you're slightly over-distending the lung. Now, as you come down, what is this distance here called between here and here? All of this, why is this line not the same as this line? What is that called? Another very important basic physiology. Laura. Okay, that's called hysteresis. All right. Hysteresis means the difference between the inspiratory and the expiratory curve of the pressure volume curve due to the air-liquid interface in the lung. Once you open the lung, or that balloon, it's easier to keep it open. As you come down on the expiratory limb, what happens is, you see that you get the same compliance on the descending limb of the pressure volume curve at a much lower pressure. Here, I'm out at a pressure of whatever, call it 20. Here, I'm getting the same exact volume, but at a much, much lower pressure. This is what we do when we recruit the lung during high-frequency oscillation. And in fact, to correctly use the oscillator in circumstances where you're first putting a baby on, you need to recruit the lung, sit there at the bedside, Go up on your pressure until you're just slightly seeing that your FiO2 is going up, and then walk back down again. There are multiple excellent articles showing how this can be done and how it needs to be done. But it's not all that hard as long as we're remembering that when a baby needs to be recruited, we need to sit down, recruit the lung, back off, and find the area where we're at, what? A minimum FiO2. And we're on the descending limit of the pressure volume curve. This is one of the major reasons that oscillation is inappropriately used, is that these kinds of concepts are not well understood. And just sticking a kid on an oscillator and walking away is absolutely the worst thing that you can do. It's a little bit more finesse is needed in order to find where we are on this curve so that we can ventilate our babies at the optimal mean airway pressure and the optimal decreasing limit on the pressure volume curve. When do we need to do that? Most importantly is when we initially put a baby on the oscillator. That's the most important time, because when they're stable, you're fine, you're okay, all right? You've done it, you're good, no problem. But when you're first putting a baby on, and that's why we've been talking about how important it is that we be at the bedside, so we can sit down and we can do this. We can slowly go up, slowly come down, find that place where the FiO2 is at a minimum, and that is critical, particularly after surfactant, or a baby that you're just putting on. Maybe he's got some other problem, maybe he's got pulmonary hypoplasia, whatever. That is number one time when this needs to be done. Number two, after any disconnection. I'm always saying, never take the kid off. Please never take the kid off if you can avoid it. What happens when you take the kid off is that the lung de-recruits. Once the lung de-recruits, if you just put him back on again, is he going to be at the same place? No, he's not going to be at the same place. He's de-recruited. So the usual recommendation for that is to go up 1 or 2 centimeters on the mean airway pressure, stay there for 5 or 10 minutes, and then go back to where you were. A very simple way that we can do, write it in a protocol or something, that will re-recruit that lung to where it was. Of course, you can't walk away and forget it. You have to bring it back down to where it was before. But usually 5 or 10 minutes on 1 to 2 centimeters of higher water pressure will bring that lung back to where it was, then you back down again. The third thing is after suctioning, and David Tingay from Australia has done some beautiful work on suctioning during oscillation. It seems to be probably a little bit better to use inline suctioning. You do actually lose a little bit of lung volume. And a better way to deal with the patient after you suction him is, again, go up 1 to 2 centimeters, stay there for 5 to 10 minutes, and then go back to where you were. These are 3 areas that we, in our nursery, can be aware of in terms of optimizing our mean airway pressure on the oscillator. And I've got articles on all of this if anybody wants to see. So I say this, I try to say it again and again and again and again. We need to recruit what needs recruiting and wean what needs weaning. The case on the left is a massively hyperinflated, and I can guarantee you that that lung will be as damaged as if inappropriate tidal volumes were used during conventional ventilation. The lung on the right, ignore for the time being the fact that the endotracheal tube's down the root main stem, needs to be recruited in a big way. So the most common errors that I see with use of oscillation is not recruiting when the lung is alactatic, and the hell with the rib count. I hope everybody takes rib count and forgets it ever existed, because that's not the most important thing you need to look at. And not weaning fast enough when it's time to wean. On this baby, going down by a mean airway pressure of 1 is totally inappropriate. All right, that baby needs a wean of 3 or 4. That baby needs a big wean. That baby has impeded venous return from the brain. That baby is at risk for pneumothorax. That baby has a very small heart, and the cardiac output is low, and the lungs are being damaged from hyperinflation. So when you make a wean or when you make an increase, remember, how bad is my lung? There's nothing magic about some certain number. You have to apply the appropriate number to the appropriate baby. If X-ray appearance, unfortunately, is not very reliable. I see a lot of people trying to count ribs on films that are so rotated you can't even tell what side of the chest the ribs are on. Also, even if you have a completely straight film, babies' rib counts vary depending upon what's going on with the child. I saw somebody count ribs on a kid with pulmonary hypoplasia at one time. How silly is that? The kid is going to have maybe 6 ribs because he has no lungs. So what you're going to do is you're going to look at what? The diaphragms. If the baby's overdistended, the diaphragms will not have their normal convex appearance. They'll be very flat, right? So flat diaphragms, bad sign. Heart size. If the heart is squished, bad sign, no matter what the rib count is. And the lung fields. The biggest thing people don't look at is the lung fields. Are they atelectatic or are they over clear? If they're over clear, the baby's got too much mean airway pressure. If they're atelectatic, he doesn't have enough. I don't care what the mean airway pressure is. Now there are some problems, and the problems come when you have both atelectasis and overinflation. And that's where we bring out the jet, and we'll talk more about that next time.
I just have a question. You know, the classroom teaching to bedside application. One of the independent variables with our recent pneumo is lack of weaning with CO2 correlating. When we talk about an oscillator weaning, what the clinicians, the bedside need to know is, you know, we do not have a pressure volume curve, okay? So the weaning is based on, like if you have a conventional, you have a curve, you can look at the complaints, you can wean. So we are stuck with either an X-ray finding to wean, or what are the other parameters if we don't have an X-ray? Can we focus a couple of
FiO2, FiO2, FiO2. These are the two things we have in our clinical situation today. And if you have a baby that really needs to be weaned, I, again, would sit your butt down at the bedside, because this is a very dangerous situation. Whoops. This is a very dangerous situation there on the left. What I would do in that situation is drag up a chair, sit down, start weaning my mean, and watch my FiO2. What do you want to do? You want to wean until your FiO2 is at a minimum. I don't know if that's going to be weaning by a mean of 10 or a mean of 2, but you have a problem there. You have a high risk for pneumothorax. You have a high risk for an IVH. That should never happen, for one thing. We should be on top of our kids enough, looking at the FiO2, looking at the periodic x-rays, that should never happen. But if it does happen, and shit happens, if it does happen, then you sit down and you wean that kid. I actually feel the same way about the one over here, because I don't know how much wean that kid's going to need. Is he going to open up with 2 or 3, or am I going to have to go to 15 or 20 or higher? The only way I'm going to know that is sit down and watch my FiO2 as I change my mean airway pressure. Managing oscillation correctly is time intensive. Until you get the kid very stable and where you want him to be, all right, it's time intensive. The lung is a changing dynamic organ when you've got this kind of thing going on. All right, and just walking away is how we get into trouble. That's how we get into trouble.
So besides FiO2, does blood gas really help us in weaning?
Your TCOM will help you, because you really need to know what your CO2 is. And we really get into a lot of trouble if our CO2 is particularly too low. And you remember from those of you that were at either the webinar or the talk I gave on CO2, I was shocked when I reviewed that data. CO2 is not only extremely dangerous in babies, it's extremely dangerous in adults. And there is a beautiful review article that I can get for you if you'd like on the dangers of low CO2 in adult medicine. And it looks like one of those things that crosses the age boundaries completely, that we should never let the CO2 go low. There's no advantage at any time for any reason for letting our CO2s go low. And for us, that in general means below 35. The data in the neonate, most of it shows that under 35 you run the higher risk of brain damage and lung damage from low CO2s. So otherwise, you're following your SATs and your FiO2, remembering that when you're at optimal mean airway pressure, your FiO2 will be as low as possible. Anton van Kamp from Amsterdam has some beautiful data where he takes kids with RDS, because in his nursery, it takes forever, even longer than here, to get his surfactant. I keep talking to him and saying, Anton, why don't you give your surfactant early, and he says, I can't get it from the pharmacy. So what he does is he sits down, puts it every baby in that unit is treated with an oscillator. They don't even own a conventional ventilator, last time I heard. But he does such beautiful oscillator work, they don't need it. He sits down with the baby, he recruits them, and it's amazing. I've got great articles from him if you'd like to look at them. Usually takes about 25 mean airway pressure, which just scares the hell out of me. These are preemies that have not had surfactant. He recruits them. His FiO2 goes to room air, all right? He brings them up to around 20 to 25, and then he brings them down to the descending limit of the pressure volume curve, where they end up at about 10 to 12, all right? Which is about where we would hang out. And then he gives them their surfactant, and they're fine. So it can be done just like we can recruit a baby with CPAP, okay, and maybe not have to give surfactant. We've all heard about that. We've all done it sometimes. We hope we'll do it more as we get more two-piece resuscitators. You can do the same thing with a sicker baby on an oscillator, because what is an oscillator? It's a big CPAP machine. That's all it is. It's a big CPAP machine that vibrates. So when we think about being afraid of using too much PEEP, think about what an oscillator is. It's just a CPAP machine, all right? So that's how the proper way to manage these kids on an oscillator is, but we have to sit down and watch them. So rib count, I really don't even like to hear about it until I've heard about the other things, because they're way more important. So the single most important factor, again, is appropriate mean airway pressure. So let's talk now about ventilation. Ventilation during HFOV entails several mechanisms that occur when gas moves at high frequency. And this is a board question, and I gave it to a small test last year to the fellows, and nobody got it right. So please remember that tidal volume affects ventilation more than frequency during high-frequency ventilation. The efficiency of ventilation approximates tidal volume squared times frequency, and that's been shown over and over. This guy by the name of Jose Venegas, who's probably the smartest guy in the world in terms of mathematical pulmonary mechanics, who showed this, and this has been shown over and over again. Tidal volume is more important than frequency during high-frequency ventilation. And this has to do with the mechanics of the movement of gas. Please don't ask me. I'm not a mathematician, and I cannot prove to you this concept, only to say it has been proven, and it is true. This is one of Jane Pillow's little diagrams. This is from the article that I gave you, and I'm not going to go over it in any great detail. What I want you to see is that there are many things going on that don't go on very much during conventional ventilation that affect the movement of gas at high frequencies. All right, lots and lots of stuff is happening that is going to mix the flow of gas and allow CO2 to be removed. And if you're interested, I highly recommend this, and I've got some other articles you can look at.
This is very good. Everybody should review it.
Probably a simpler way of looking at the basic concept is this little diagram, which I like a lot, and that is, during conventional ventilation, when you're moving gas slowly, there's plenty of time for equilibration of pressures. The gas that goes in at the endotracheal tube is the same pressure as the gas that is seen at the alveoli, all right? Same waveform. This is because the gas is moving slowly. However, during high frequency, you've got a tremendously fast movement, and so what happens is that pressure waveform becomes attenuated. So what we may see is, let's say, a delta P of 20 up here at the airway. I'm going to set a delta P of 20 on my baby. What is that? What are the units of that? It's a pressure. It's centimeters of water. Does that mean that the baby's saying, oh my God, 20 centimeters of water? No. Actually, with a 2.5 endotracheal tube, the attenuation is 90%. And what the lung sees is 2 centimeters of water, delta P. So you can see that that tidal volume is way less, all right, which is one of the advantages of high-frequency ventilation. One of the great advantages, provided that you can use it appropriately with an adequate mean airway pressure and a small tidal volume. And remember that your tidal volume is going to affect your ventilation more than frequency. All right, so a few things about different settings. Flow. That's a tornado in Kansas. See, I grew up in Kansas. We saw those things all the time. Pretty scary. Use the lowest flow that will generate your mean airway pressure, because high flow causes turbulence and increased airway resistance. It used to be, for those of you back in the old days, that the sensor medics was always set at 20 liters per minute. And we still have some people around who do that. One of the things you need to do when you look at the ventilator is see where the flow is, because it's usually set by the therapist, and they're getting much, much better at it now. In fact, I haven't seen 20 in a very, very long time. Little tiny babies don't need more than about 10 liters per minute. Some need less. So just check it and make sure that it's at some sort of reasonable place. Now on the big adult machines, the flow can go up very, very high because they're powerful and they're meant to ventilate adults. So we sometimes get a SensorMedics B in this unit. Please be aware, because the B is an adult machine. It doesn't mean it can't be used on babies, but it has a lot more power, and by mistake, things can happen. So be very, very, very careful. I think the flow goes, what, 60? 60. It goes up to 60 liters a minute. All right, so you could make the baby float up through the ceiling easily. So be very, very careful about that. Inspiratory time, we've talked about the fact that it's an IE ratio. The IE ratio does not change. The actual inspiratory time is going to vary, of course, with the frequency. And here is a point that very few people know, but it's been well documented in the literature, and that is that the flow characteristics resulting from this 33% inspiratory time result in a 1 to 2 centimeter interpulmonary pressure drop across the lung. And this has been measured by alveolar capsules, which are glued to the lung of the animal, not the baby, and pressures have been measured. This is why we typically start HFOV mean airway pressure at about 2 centimeters higher than on CB. It has nothing to do with, oh, I need a higher mean. You are, in fact, putting the baby on the same mean because of this pressure drop across the endotracheal tube. That's perfectly okay. If you want a higher mean, then you're going to have to go higher than the 1 to 2 centimeters. And that is a very important point that very few people know, and please keep it in mind. If you want a higher mean, then don't go 1 to 2 centimeters, go 2 to 4 centimeters. Go higher than what you are on conventional, because when you go up by 1 to 2, you are using the same mean. And that may be fine. In fact, most of us do start at the same mean, just so we can get an idea of where we are and where we need to go from there. If you wish to treat air leak with oscillation, remember that air leak, you want the lowest pressure that you possibly can have. So if you wish to treat air leak, consider starting at a lower mean than on conventional. And there, even though we will talk later about the possibility of jet being a better machine for air leak, if you do want to use the oscillator, your mean needs to be lower than on conventional. Yes, Sean?
If your lungs are already hyperinflated with PIE, how does the oxygenation help when you start with a low MAP than conventional? Don't you think jet would be preferable there?
I do. I'm just saying if you want it for some reason.
So I just wanted to know, like, you know,
yeah, I mean, I would
depends upon the
not,
physical properties of the lung as well, like, you know.
Yeah, I would not recommend the oscillator for air leak at this time.
When you have a hyperinflation, I mean, you're already hyperinflated, your problem is oxygenation. Even when you start with the low MAP, it may not help. Right?
It may not.
I just wanted to apply the bedside application as we are in the classroom so that we all understand a little bit better.
Yeah, it can, and if you do choose, maybe the jets are both broken or whatever.
Yeah. Does the low MAP help here? That's what
it does, because theoretically it will help you resolve some of the tearing of the interstitium from the PIE. But ideally, the jet, because of the way it works, is probably better for that. So with air leak, I think most people are using the jet. But if for some reason all you've got is an oscillator, and that actually happens in a lot of places, and it certainly happens in Europe. The jet is not available in Europe, so if you happen to be in London and somebody asked you to treat a kid with an oscillator with air leak, I would tend to start with a little lower mean airway pressure and see if that will help resolve the situation. Of course, the advantage is that you're not opening and closing those lungs, so it potentially can work. It certainly can work, but the jet may be a little bit more effective. All right, Hertz. This is always a confusing thing, and it's certainly not totally worked out even among those who are studying it. Just remember that the lower the hertz, the closer you are to conventional ventilation, because your tidal volumes are going to get larger as you lower the rate. All right, remember the little picture with the tidal volume being just like conventional on a low rate and very much attenuated on a high rate. The goal is to avoid that tidal ventilation. The goal is to hold the lung open and just vibrate the lung with as low a tidal volume as you can. In general, and this has to do with a whole lot of stuff, and I'll give you a little bit of information that may help you. In general, preemies we use around 10 to 15 hertz, term babies 8 to 10 hertz, and children 5 to 8 hertz. There are some caveats, but this is just a good kind of general thing to keep in mind. Now, here's some information that might be helpful as you try to figure this out. High-frequency gas transport mechanisms start at lower frequencies in large animals or adults. In other words, remember we talked about all that stuff that's going on, all those things in Jane Pillow's diagram. All right, that's going to start at lower frequencies when you are a adult, or when you are a large pig or an adult sheep or whatever. All right, those kinds of physics change at lower frequencies in large animals or adults. Lower frequencies should be employed in cases of high airway resistance. And if you think about that, that makes a lot of sense. All right, so if you have a kid with meconium aspiration and he's got high airway resistance, think of it as this whole situation of an asthmatic. You're going to want to use a little bit of a lower frequency, just like you would on a conventional ventilator. Now, this may be helpful. There's something called the corner frequency. And the corner frequency is that which beyond the response is going to go down. All right? And the corner frequency, and this has been worked out by Jose Venegas, and it's very, very complicated mathematics, but I've got the articles if anybody wants to look at it.
Can you send that article?
Jose Venegas, absolutely. Is equals 1 over 2 pi times the resistance and compliance. Now, what's resistance times compliance? What's that called? Shuttle, you have your work cut out for you. Another extremely important, I don't know, Sharia, were you at last year's talk on resistance times compliance is called what? It's the time constant of the lung. All right? I guess we'll go into that more later. But if you look at the reverse relationship here, you can see that if you have a high resistance, what? Your frequency, your effective frequency will be lower. It's inversely related. If you have a high compliance, your frequency will be lower. If you have a low compliance, your frequency will be higher. So when we have infants with RDS, with a very low compliant disease, the frequency needed is going to be higher. So I'm not going to go into all the math because I don't even pretend to understand it, but I found this very helpful in trying to figure out why we use higher frequencies or lower frequencies in some conditions. So it depends on what's going on in the lung, and it depends on the size of the lung. Okay? So the bigger the person, the lower the frequency, the higher the resistance, the higher the compliance, the lower the frequency, and vice versa. So ventilation, again, depends on tidal volume more than frequency. Larger endotracheal tube and lower hertz markedly increase the tidal volume, so be very careful. This is why we do not go down on the hertz unless we absolutely have to. Lower hertz for increased airway resistance, such as BPD or meconium aspiration, because of what we just talked about. So be changing your delta P first. It's a much more sensitive way to change. If you change the hertz, it's like taking a hammer. All right? And sometimes we need to. We've had kids where we've gone up on the delta P, it just hasn't worked. We've had to lower the hertz. But that is not your first choice. Your first choice should be adjusting your delta P because you have much more control over the tidal volume. The goal is to have adequate gas transport with the lowest possible tidal volume so that we avoid tidal ventilation. Some old wives' tales of high-frequency oscillation. Mean airway pressure and delta P must be the same. I have no clue where that came from. I find it amazing. Every once in a while it actually turns out that way. But it's completely silly, and there's no reason why it should be. As you wean the baby, your MAP and your delta P are going to be lower, so I suppose they could end up the same at some point. Babies must be paralyzed during HFOV. We don't do that anymore, but it used to be thought that should be done. It's actually quite comfortable. When HFOV was first being tested, some adults tried it. They had themselves intubated, and it's a little bit farther along than I would go, I believe. But afterwards, they said it was extremely comfortable, and that they didn't want to breathe. That they lost, when it was an appropriate setting, they lost their desire to maintain their own spontaneous respirations. If the baby is breathing, it's fine, but if he's really working, the likelihood is that you don't have enough support. Either your mean airway pressure is insufficient or your delta P is insufficient, because he's obviously shouldn't be fighting you and breathing really hard, because that means he's working and he's not getting enough support. Another old wives' tale is that babies must be weaned from HFOV to conventional, which I've never understood, because the whole thing you're trying to avoid is conventional ventilation. Now, this is not true in big babies and in adults or in kids, because they are able to pull enough pressure that they can actually stop the oscillator. So they have to be sedated. Unfortunately, they often have to be paralyzed, and they have to be weaned to conventional. Our babies don't. Our babies don't pull enough pressure that they shut off the machine. So they can be kept on the oscillator until they're weaned.
Just going back to the other side, when you're weaning, just to remember, or maybe you could just talk about how if your amplitude is decreasing and you're weaning adequately, sometimes it looks like you're about to go below the mat on your amplitude, and not to do that.
That is another old wives' tale that has never ever been demonstrated. It's called, Burt Bonnell used to talk about this, and I used to slap him upside the head because he never had any data. It's called choke points, and it's a complete misunderstanding of what's actually going on with the oscillator, because of the attenuation that you have, that basically can't happen. You know, you would have to set it in the most bizarre way for that to ever happen. So if your mean airway pressure is, let's say extubatable, let's say 8, something like that, and your delta P is, say, 18, you would say, oh my God, that 18 is going to pull way below the 8, and the baby's going to have a choke point, and he's going to shut off the oscillator. Well, your 18 is attenuated so much that you're only seeing, what, 2 to 3 at the actual airway. So nothing's going to be shut off. Nothing's going to happen. It can't happen. And I don't even know how you would do that other than set the oscillator at such a stupid setting that it would be totally ridiculous. Now the whole point about can the active exhalation cause at some points in the lung a narrowing of the airway and cause what's called a choke point where gas has more trouble getting through. This was theorized by some people, never been proven, never been shown, and really to me doesn't make any sense because you've got the dilation of the mean airway pressure holding the airway open. But you will hear sometimes people that, some people that are in the area, you'll hear them talk about that as a possibility, never been shown, never seen anything on it, neither has anyone else.
What about when the MAP and the amplitude are essentially the same?
Huh?
I've seen that too.
I'm sorry?
The MAP and the amplitude are basically the same number.
I've seen it. I mean, it can happen. Why not? I mean, but it doesn't do anything.
Okay.
I mean, you can't because your amplitude is going to be way less than what's set on the machine.
If you have to wean, you have to wean.
You know, and I've heard, oh, they must be the same. I mean, where the hell did that come from? I mean, that's just ridiculous. I mean, your MAP is what? Is wherever it needs to be for your optimal mean airway pressure.
Right. I've just heard people say, oh, we can't wean any further because the numbers are the same. And
this is why I have this word.
That's
here.
why it's
old
up
wives'
there.
tale, okay? How low will the MAP go? It will go to 3, all right, which is completely stupid. The baby ought to be extubated at least by 7.
8 or 6, you know.
How low will the delta P go? It will go to 9. It usually won't hold at 9. It'll usually start ringing off, but it will go. That's how low they will go, okay?
But the only thing you need to see when you put that low delta P, when you have a 2.3 OQ in a tiny baby, that baby may stop oscillating. then your FAOD will go up, then you need to suction the airway and make sure the resistance is removed. So again, we have to look at the big picture.
And I've actually just turned the oscillations off, the same way that I've put kids on pressure support, and just said, because what are they on if the oscillations are off? What are they on? CPAP. Hello? So if I have any worry that the kid might, get apneic and fail, I don't walk away. I sit down, I turn off the oscillations, and I say, are you going to breathe? And if he breathes, then, then pull the tube. Okay? So we're not going to get through the rest of this, but I may start here next time and then work my way into the jet talk. This may actually be a good place to stop. Yes, sure.
I'm sorry, can you recommend a specific gestational age or birth weight to just right away start the baby with the jet? Or again, we should look at the big picture.
We're going to talk about that. This is what I'm coming up to now. So I think probably I'll stop here, and I'll never get through the rest of this. So.
Can you fill one?
Get on these sides.